Hello, my name's Professor Kausik Ray. I'm Professor of Public Health and Consultant Cardiologist at Imperial College, London. I'm the Deputy Director of the Clinical Trials Unit, and my interests are in large-scale population research, so observational studies and clinical trials. So I want to focus today on talking about the role of antiplatelet therapy for the primary prevention of cardiovascular disease in people with diabetes. Now, if you start by looking at the epidemiological data, we know that diabetes doubles the risk of cardiovascular disease approximately. Now, most of those events are going to be case fatalities, so the first event is often a fatal one. And when you take into account various other factors that cluster with diabetes, you can't explain the excess risk, the twofold excess risk, by things like lipids, blood pressure, cholesterol, smoking, etc. So that means something else is potentially there that might be contributing to risk. You might say that glucose isn't there, but even when you adjust for glucose, that difference doesn't attenuate, doesn't go away. Now, we know that diabetes and several other risk factors are associated with endothelial dysfunction, and that basically produces a procoagulant phenotype. So the endothelium produces less anticoagulants and produces factors that resist fibrinolysis, so like PI1. So basically, the endothelium promotes a procoagulant phenotype. And it's in that area that there's been a lot of interest in antiplatelet therapy. Now, platelets are extremely complex in that there are a whole host of potential triggers that can activate the platelets and also lead to platelet aggregation. One of the treatments that reduces platelet activation, as we all know, is aspirin. And other important targets are the P2Y12 receptor, which is the target of clopidogrel, of ticagrelor, and also prasugrel. Given that diabetes is associated with an excess risk of thrombotic disease and might be associated with a procoagulant phenotype, it's no wonder that there has been interest in the use of aspirin, not just in primary prevention in diabetes, but in general populations. Early studies had suggested there was benefit from aspirin, but later studies started to suggest that there was less benefit. So one way to try and look at this is to quantify the data. So if you look at the entirety of the world data, and one of our meta-analyses that we did several years ago, looking at 100,000 people, 700,000 person years of follow-up, the effect of aspirin in primary prevention is simply to reduce non-fatal MIs without reducing cardiovascular death, without reducing all-cause mortality, without reducing stroke, and increasing the risk of bleeds. So non-trivial bleeds is what we used, and that could be things like intracerebral bleeds, death from bleeds, needing a transfusion, and needing a hospital procedure to stop bleeding. So these are bleeds that are not, for example, I've just cut myself shaving type scenarios. So you're talking about major bleeds here. And if you look at the data, for example, around this, then the benefit of aspirin was certainly seen pre-2000, i.e. post-background therapy like blood pressure, lipid lowering, smoking cessation, all of these things coming into place. There has been little evidence that aspirin is of benefit. If you are going to take aspirin, then the bleeding risk is significantly reduced by alternate day dosing. You still get the same benefits on non-fatal MI. And quite simply, there is no level of 10-year risk at which the number of events prevented exceeds the number of bleeds caused. And as a result of that, there is really no evidence that aspirin in primary prevention should be used. If you move specifically to diabetes patients, the ASCEND trial, 15,000 people, looked at aspirin primary prevention. And although it did reduce the composite of cardiovascular events, there was no effect on significant reduction in non-fatal MI, on strokes. The composite endpoint was driven largely by some reduction in TIAs, but there was roughly about a 30% increased risk of bleeding. And if you look at different risk categories, so less than 1% per year risk, 1 to 2% a year, or more than 2% per year risk, the number of events prevented is exactly identical to the number of bleeds caused. And therefore, as a result of that, there is really no routine use of aspirin in the general population. Now you might say, what about older patients? Well, the second study that was done that was really important was the ESPRIT trial in people with an average age of 74. And this also showed that there was no benefit, for example, in cardiovascular death, non-fatal MIs, but there was an increased risk of bleeding, and there was also no benefit, for example, in cancer deaths. So that really is the totality of the data for aspirin. What about other agents? Most dual antiplatelet therapies are used in the post-ACS, the post-MI setting, or the post-stroke setting, but that's not what we're talking about. And there is one trial that was completed last year called THEMIS, and it was looking at population with diabetes who are at high risk of cardiovascular disease with evidence of coronary disease. So this could be prior PCI, prior CABG, angiographic stenosis of more than 50%, but no MI and no ischemic strokes. And if you look at the overall benefit in that trial, and the dose of ticagrelor that was used was 60 milligrams twice a day, you could have background therapy with aspirin, largely because some guidelines in the world when the study was started still advocated using that, and that's now changed. But that was the background therapy. 20,000 patients, average follow-up 3 years, about a 10% reduction in the primary endpoint, but there was an excess risk of bleeding. There was quite a lot of interest in trying to identify groups where the net benefit might be greater, might actually favor the use of ticagrelor. And so there was a second analysis done that was published in The Lancet, and this basically showed that if you look at people who had a prior angioplasty, they did much better, more like a 15% relative risk reduction on average, and in the group without primary PCI, not primary PCI, PCI, no real benefit whatsoever. And if you look at net benefit, and if you look at using both bleeding and the efficacy endpoints in the same analysis, you find that that's the group that there is a benefit in. You are preventing more events than bleeds that you're causing, unlike the situation in the people who'd never had a PCI. And the second analysis from that was the timing of benefit from the time of PCI. And the benefit seems to be there certainly in the first 5 years or so. So if you've got historically a patient that you see that you haven't seen for 10 years after the PCI, there's probably no place for ticagrelor in that situation. But in your stable patients, for example, there's suggestion that there's certainly benefit over a 3-4 year period. So in summary, aspirin, there is no role in primary prevention in diabetes. Amongst your patients with diabetes who have got coronary artery disease with no prior history of ischemic events, and in particular who've had a PCI, that's where there may be a role for ticagrelor in terms of reducing the risk of atherothrombotic events without a significant excess in bleeds. Thank you very much for listening.